the way I look at this with hypothyroidism is for people with symptoms or maybe even with a diagnosis, I would like for them to have the right diagnosis and the correct treatment and to avoid incorrect diagnoses and therefore incorrect treatment. That may be overly simplistic, but from my perspective, I see so many people who've been given incomplete, incorrect advice. So that's kind of how I frame this conversation, very, very high level. How do you think about this?
So it is important for us to know what is hypothyroidism. Many patients come and say, well, I have hypothyroidism, but the tests are normal. TSH is normal, free T4 is normal, right. T3 is normal. Who gave that impression? The presence of positive TPO antibodies.
Yes.
So many patients have positive TPO antibodies and they say, well, I have hypothyroidism, I need to be treated. And we know that that does not trigger treatment. That just tells us that the patient has in their blood antibodies against the thyroid. So they could develop hypothyroidism in the future. They could never develop hypothyroidism. They could be positive for the rest of their lives and the thyroid be working well. So it's really hard to predict. I think that with those patients, what we do is every 6 months, we check TSH to see if there's a progression. It's interesting because hypothyroidism is quite straightforward to make the diagnosis. We have a very good method, a biochemical method, which is measuring serum TSH. And for most patients, serum TSH is the perfect tool to make the diagnosis of hypothyroidism. Of course, there are patients in which we cannot use TSH. Those are patients with central hypothyroidism. But those are, we're talking about 1% of the number of hypothyroid patients.
Right.
Even though it's a small percentage, if you think that we have 20 million patients with hypothyroidism, 1% turns out to be a significant number. So I think we should always keep in the back of our mind that people with central hypothyroidism exist, and we can't trust the TSH for those individuals. But that's a rare condition. Let's say we can't trust the TSH, okay? So it used to be that you need to have a high TSH, and then I'll make the diagnosis of hypothyroidism. Now, over time, that high TSH, how high is high? The threshold for me to say, well, you do have hypothyroidism is coming down. It used to be greater than 10. Right. Now, however, the upper limit of normal is 4.5, and there's a gray zone between 4.5 and 10. And what do we do with those individuals? And that is something that's called subclinical hypothyroidism, because patients are supposed to have only minimal symptoms. But I think it has to be decided on a case-by-case basis. And so I do believe that it's not that complicated. It's just that we as you said, we need to look at what's in the literature, what people have done, and because sometimes it's really not beneficial to go with treatment. And in other cases, it is beneficial for two patients that have the same TSH value.
So as to make sure we don't lose the important objective of giving you the diagnostic criteria straight talk, here they are. Really two ways of diagnosing hypothyroidism. A high TSH, defined as above 4.5, which is the cutoff for LabCorp, Quest, all your big box conventional labs. So a TSH of 4.5 or higher, paired with a low free T4, and the free T4 range is between 0.8 and 1.8, again, at your big box labs, LabCorp, Quest. So that's one, a high TSH paired with a low free T4. Very important, according to the conventional lab ranges, not what your doctor may alter and use sort of these different, more contemporary ranges, which are not correct. So that's one. Two is where you actually have normal free T4, but you have just an elevated TSH. And this is where I think people get into the most trouble. Because as this diagram articulates, again, this is when looking at solely elevated TSH. So the free T4 is normal. When your TSH goes above 4.5, you are what's known as subclinical hypothyroid. So you could be 5, you could be 5.5, you could be 6, you could be 7. You really don't get into a position where you'll benefit from thyroid hormone, where you're considered hypothyroid, until your TSH gets somewhere above 7 to 10. So that's this transitional zone. And we have pretty compelling data that have answered this question. People in this subclinical range do not seem to have problems. They don't have more symptoms, and they certainly do not seem to benefit from thyroid hormone replacement therapy. However, when people get past this transitional zone of 7 to 10 and they're above 10, maybe above 7, when they're in this range, this is where people seem to benefit from thyroid hormone. So why this is so relevant is there are a lot of people, it appears, being given hormone when their TSH is subclinically elevated, subclinical hypothyroid, and these people do not benefit from treatment. And sadly, they oftentimes start on lifelong thyroid hormone replacement therapy. So bear this in mind, very, very important. Now, I also wanted to mention that we do have a course we've developed to help you with this. And part of the reason why I'm so proud of this course is, as you may know, we published 2 papers on the gut-thyroid connection and more broadly articulating how the misdiagnosis of hypothyroidism is quite rampant and sadly leads people to have subpar care. And this is the course homepage along with the 2 papers that we published. So in addition to Dr. Bianco's book, which I would recommend, obviously because he really knows his stuff and I was impressed with his degree of knowledge, we have a course here that really puts all this together. And how I think this will complement Bianco's book is we go a bit deeper into dietary, lifestyle, and supplemental interventions like selenium ionositol, amongst others, for improving your thyroid health. Hey everyone, by the way, if this video has been helpful, please comment, like, and subscribe. Especially the comments are very helpful for me to hear what you find noteworthy and what questions that you have. And also like and subscribe so you see future videos from us. The other thing that you said that I also have discussed in the podcast in the past, I feel is really important to highlight, is this paper by Levadas. This is going back maybe to 2019, where they were looking at this what they called ambiguous hypothyroid diagnosis. And they found about 61% of patients who are on hormone could stop the hormone and maintain normal TSH and had no regression of their symptoms. It was followed up by a meta.
Yeah, no, I know the study.
Well, then the meta-analysis from maybe a year later found about 37.1% of people could stop their medication. So there's a decent subset of people probably watching this. If that meta-analysis is correct, maybe 1 in 3 who are viewing this might be on a hormone that they don't need.
Right. And it's just crazy. And this is exactly what I was mentioning earlier. Patient comes to the doctor, has a TSH that is 5, has symptoms, and the doctor, without further investigation, will just start that patient on levothyroxine. And the patient is going to be labeled hypothyroid for the rest of their lives. And they will blame everything that's wrong with them to the hypothyroidism that, in fact, they might not have. So I think that's really important. And so in my practice, I would say that I would take patients off levothyroxine because you need to be certain of the diagnosis before you treat someone with the specific medication. So if you're not certain, if a patient cannot show me an elevated TSH that I can convince myself that patient has hypothyroidism, is really hard to continue without further investigation.
This is a crucially important point that you make. And we're seeing the same exact thing. And so now even in our paperwork, we ask a few questions. How was your hypothyroidism diagnosed? Was it diagnosed by a conventional provider who was kind of conventional practice, or was it more integrative, anti-aging, functional? And then we'll pair that with, do you have a family history? right? Family history suggestive. And what was your TSH at time of diagnosis? If you don't know, see if you can find it. And it's a pretty short list. Again, straightforward, like you said a moment ago. If it was diagnosed by an unconventional provider, it throws up a flag for me. If there's no family history, throws up another flag. And then the most important thing is at the time of diagnosis, their TSH might have been a 3.9 and their T4 might have been, let's say, 2 at the lower end of normal, but still within the normal range. But the provider says, oh, there's these new values that are more narrow.
Oh, yeah.
Those are the ones we have to follow. Now you're hypothyroid. And the real travesty. Yes. And then the real travesty is this person brings that diagnosis forward to other doctors and no one thinks to question it.
Exactly right. Any chronic condition will cause symptoms, in my experience. And I have to say, this will depend on the specialty, depends on the practice, depends on the area. In my experience, the most relevant confounding factor is menopausal syndrome, because you cannot tell the difference between perimenopausal symptoms and hypothyroidism. You know, the skin gets dry, you're gaining weight, the hair is falling, constipation, low energy, memory is failing. The symptoms are very, very similar. So I start by measuring FSH. Let's see what is the status of how's the ovary functioning. And from that point on, I'll just go, as you mentioned, iron deficiency, anemia, vitamin B deficiency, all sorts of other autoimmune diseases that we know are prevalent in patients that have already one autoimmune deficiency. It's more likely to have a second one. So I think that most of the time we end up finding a reason for those symptoms.
It's funny because our clinical observations are just incredibly similar.
Yeah.
And this is one of the things our clinical team in our paperwork is looking for. We have a list of female hormone symptoms. And so what you may see, their chief complaint is dry skin, depression, and fatigue.
Right.
And they don't mention their cycles are irregular. Maybe they have heavy periods when they do cycle, and they're having hot flashing. And so when you put those together, now you're saying, well, it's probably not hypothyroid. It's probably your female hormones.
Absolutely.
And it's been alarming how many people have been kind of shoehorned into thyroid when it really seemed to be their female hormones implicated. I'm sure you've seen similar where the healthcare provider, again, always assuming is well-intentioned, but they've been educated that we're targeting the upper half or upper fourth of T4 and of T3. And someone comes in and they're either at the upper end of the range or they're elevated for T4 or T3 or both. And TSH is suppressed and the patient's saying, I'm not feeling good. I'm developing osteoporosis. I'm not sleeping well. And it's like, holy smokes, you're just trying to juice the thyroid system and you're totally discarding this really important concept, which I call the Goldilocks zone, right? The bell curve. We want to be in that appropriate zone biologically. Too much, not enough is where outcomes are poor.
Yes, I agree. And unfortunately, there are many doctors that disregard TSH and will just blast thyroid hormone and in order to make the patient feel better, but ignoring the fact that we are creating a condition that's called thyrotoxicosis.
Yeah. And again, just to echo for people, because I think fatigue and depression might be two of the biggest complaints I think at least the patients I work with suffer with. And you can make that worse with too much thyroid hormone.
I think the most important message is symptoms associated with hypothyroidism are not unique to hypothyroidism. All symptoms, they can be triggered by other conditions. And the fact that you have dry skin, constipation, and your hair is falling doesn't mean you have hypothyroidism. So don't blame the TSH for being normal. It's just that maybe there are other explanations for the very absolutely same symptoms. And I think that we don't do a good job explaining that to patients. Patients need to understand that. And yes, many patients will have hypothyroidism, but not necessarily, not all of them.